So let's discuss on acid-base disorder. Before acid-base disorder, I had a comprehensive discussion onto the acid-base balance in the body. Actually, the acid-base disorders occur when the body's normal balance of acid and bases is disrupted, causing the plasma pH level to deviate from its normal range. So we will see here. So disorders of acid-base balances are acidosis and alkalosis. What is the alkalosis and acidosis? So acidosis may be defined as an abnormal condition caused by the accumulation of excess acids in the body or by the loss of alkali from the body. Both sounds the same. So that condition is known as acidosis. In the alkalosis, what happens? There is an accumulation of excess alkali in the body or by loss of acids from the body. So, acid-base balance depends on the ratio of carbonate ion and carbonic acid. If we remember the Anderson-Hasselbalch equation, so concentration of bicarbonate to carbonic acid, so that ratio is always 20:1. So, at physiological pH. So, any alteration produced in the ratio between the carbonic acid and the bicarbonate results in the acid-base imbalance and leads to acidosis and or alkalosis. Now, acidosis and alkalosis again can be classified in terms of their causes. So, first is the metabolic acidosis. It is the decrease in the concentration of bicarbonate ions. And the respiratory acidosis is in respiratory acidosis, there is increase in carbonic acid concentration. And metabolic alkalosis increase in the bicarbonate concentration. And respiratory alkalosis, it is decreased in the concentration of carbonic acid concentration. So the metabolic conditions, the metabolic acidosis or alkalosis happens once there is a deviation in the level of bicarbonate. That is the conjugate base or the numerator in the Henderson-Hasselbalch equation. This is bicarbonate. And so in both the cases, in acidosis, there is a decrease in the bicarbonate ion, while in the alkalosis, there is a metabolic alkalosis, there is a increase in the bicarbonate ion concentration. Opposite to this, in the respiratory acidosis, there is an increase in carbonic acid concentration or thereby increase in the partial pressure of carbon dioxide, or respiratory alkalosis, that is decrease in the concentration of carbonic acid concentration or decrease in the partial pressure of carbon dioxide. So carbon dioxide as such, it is not present in the blood in this carbon dioxide form. Rather, the carbon dioxide is always present in the form of carbonic acid. So in this dissolved form, carbon dioxide moves from the tissues to the lungs, and then finally it's broken up into the water and carbon dioxide, and it is expelled out through expiration. So there is a clear concept. Metabolic states are concerned with the deviation in the bicarbonate level, while the respiratory conditions, acidosis or alkalosis condition, are concerned with the partial pressure, deviation of the partial pressure of carbon dioxide or carbonic acid concentration, right? So now in detail, let's see what is the metabolic acidosis. It is a fall in pH, blood pH, due to decrease in bicarbonate level of the plasma. It is called as metabolic acidosis. So pH is the first indicator about the acidosis or alkalosis state of the body, whether it is metabolic or it is respiratory. If there is a fall in pH, so it is definitely a type of acidosis. If there is an increase in pH, it is the alkalosis state. Then further, by other parameter, we will decide upon whether it is metabolic or whether it is respiratory. So a fall in, the first indicator, fall in the concentration of in the pH, right? So second is the decrease in the bicarbonate level. which I have already told you, like metabolic states are concerned with the deviation in the bicarbonate or conjugate base of the carbonic acid. So always look into the normal range, and if there is a deviation from the normal range of bicarbonate. So normal range of bicarbonate is from 22 to 26 millimoles per liter. So increased production of acids. So this bicarbonate level, how or when it is decreased, it is due to the increased production of acids, like in uncontrolled diabetes mellitus and starvation. These are the two very common conditions in which we can observe the state of metabolic acidosis. So, and or excessive loss of bicarbonate in the from the renal tubular due to the renal tubular dysfunction and in severe diarrhea. So these are the major causes for decrease in the concentration of bicarbonate level. So how it is being compensated? Because body has adaptations to come to cope up with these abnormal situation, because no alterations, little alteration in pH will be disastrous, and they may lead to no disruption of life, or sustenance of life will be lost. So that's why the compensatory mechanism operate in the body to cope up with this metabolic acidosis. What are these? So first is the increasing rate of respiration to wash out the carbon dioxide. So they a kind of no small breathing or the hyperventilatory state shown by the patient. So consequently, the ratio of bicarbonate to carbonic acid is elevated. So this is the compensation of the metabolic state via the respiratory component. Then second is increasing excretion of, so at the level of kidneys, excretion of H plus ion as ammonium ion will be raised. Then increasing elimination of dihydrogen phosphate ion in the urine. So these are the all acidic contents removed through kidneys. And first is via respiratory. The respiratory rate becomes faster, so it's to remove the excessive carbon dioxide in the. So all these compensatory mechanisms tend to reduce the carbonic acid, and a compensated acidosis results. Now, respiratory acidosis. So, acidosis results from increase in concentration of carbonic acid. So, we will look into the concentration of carbonic acid. What deviation happens if it is acidosis? It is in the increase in this carbonic acid concentration, or if it is alkalosis, there will be decrease in the carbonic acid concentration or partial pressure of carbon dioxide. So this respiratory acidosis condition is from an increase in concentration of carbonic acid. So an increase in the concentration of carbonic acid is due to the decrease in alveolar ventilation, which leads to retention of carbon dioxide. Means there is a decrease in the functional capacity of the lungs. So this condition can be decreased. Alveolar ventilation may occur due to some obstructions in respiration, in pneumonia, in emphysema, and asthma. So lung capacity is lost. So alveolar ventilation is decreased. Keep remember. Then second cause can be depression in the respiration. So that can be due to the administration of respiratory depressant toxic drugs like morphine, which depresses the respiratory centers. So what is the compensatory mechanism? Compensation is through the renal mechanism. Always the like metabolic condition, the metabolic acidosis or alkalosis can be compensated by respiratory component and the renal, and the respiratory acidosis and alkalosis can be compensated by renal mechanism. So what compensation happens here? There is an increase in the renal absorption of bicarbonate so as to nullify the effect of excess acid. Then second can be a rise in urinary dihydrogen phosphates. These are urinary acid, dihydrogen phosphate and ammonium ions. Then metabolic alkalosis, a rise in pH, blood pH. Obviously, it is the alkalosis state, the pH will be towards the higher side, more than 7.4, and rise in the due to the rise in the bicarbonate level in the plasma. And this is seen in the following conditions: loss of gastric juice along with the H plus ion in prolonged and severe vomiting. Then therapeutic administration of large doses of alkali, like in peptic ulcer or chronic intake of excess antacids, people suffering from hyperacidity. So these may be the causes for alkalosis, metabolic alkalosis. So how there is a compensation? Compensation is because it is the metabolic state. So increased excretion of alkali by bicarbonates by the kidneys, then diminished formation of ammonia, and respiratory component is also involved. So there is a depression in respiratory centers who conserve the carbon dioxide. So patient will be in the hypoventilatory state. Now, respiratory alkalosis. So, respiratory alkalosis is due to rise in blood pH. It shows the increase in blood pH, and it can be due to the lowered concentration of carbon dioxide or carbonic acid due to the hyperventilation. This occurs in the following conditions like anxiety or hysteria, fever, hot bath, high at high altitude, working at high temperature. Then compensatory mechanism is through the renal. So there is increased excretion of bicarbonate ion and reduction of urinary ammonium formation. So this is how the alkalosis is compensated. So this is in nutshell. What are the causes for metabolic acidosis? So this is first is the loss of bicarbonate by the gastrointestinal tract or kidneys. Second is the increased production or ingestion of acids. Third can be the retention of acids by the kidneys. So acidosis, if it is respiratory acidosis, so the causes are hypoxia, respiratory depressant drugs, obstruction to respiration. Then metabolic alkalosis is due to the therapeutic ingestion of alkalis, loss of gastric juice with H plus ion and prolonged vomiting, then hypokalemia. So these are the causes for metabolic alkalosis. And for respiratory alkalosis, the reason can be high temperature, overbreathing, like in anxiety or hysteria, then high altitude. So due to the overventilation, so the state is respiratory alkalosis. Now this table shows the normal range of arterial and venous blood gases, because ABG analysis is one of the important handy tool in order to diagnose the state of metabolic or respiratory acidosis or alkalosis. So these are the normal values of the arterial blood gases. So we can see the pH used to be the first parameter is pH. So normal pH is 7.35 to 7.45. That is the arterial blood, and venous is 7.36. Then partial pressure of oxygen, that is 80 to 100 millimeters of mercury, and here it is 35 to 40 millimeter of mercury. Then oxygen saturation is 95% and 70 to 75% in the venous blood. Then partial pressure of carbon dioxide, that is 35 to 45 millimeters of mercury, and in the venous blood it is 41 to 51 millimeters of mercury. Then bicarbonate ion, they are the normal range is 22 to 26 milliequivalents per liter, and here it is in the venous blood it is 20, it is here also the same value, 22 to 26 milliequivalents per liter. Right, this is the base axis, so that should be from -2 to +2. Here also it is -2 to +2. And these three important components like parameter like pH, partial pressure of carbon dioxide, and the partial pressure of a concentration of bicarbonate ion. These three parameters are more than enough to diagnose about the metabolic or the respiratory disorders. So we will see in this table what happens in metabolic acidosis, what are the results of ABG analysis. So already we had a comprehensive discussion on this. So metabolic conditions are always concerned with the deviation of bicarbonate. And so in metabolic acidosis, the decrease in the plasma bicarbonate concentration and the partial pressure compensatory mechanism is through hyperventilation in order to decrease the concentration or the partial pressure of carbon dioxide. Then in metabolic alkalosis, there is increase in the bicarbonate concentration, and that is due to the increase in the plasma concentration, bicarbonate concentration. Compensation is through hypoventilation in order to increase the partial pressure of carbon dioxide, means to conserve the carbon dioxide. Third is respiratory acidosis. So it is due to the increase in both these respiratory conditions are concerned with the deviation of partial pressure of carbon dioxide or carbonic acid. So we will see here in the respiratory acidosis, increase in the partial pressure of carbon dioxide, and compensation is through renal mechanism. So increase renal bicarbonate reabsorption, and that increases the plasma concentration of bicarbonate. Then respiratory alkalosis, there is a decreased partial pressure of carbon dioxide or carbonic acid. So compensation is through decrease in the renal bicarbonate reabsorption, means more bicarbonate has to be lost through kidneys in order to decrease the plasma concentration of bicarbonate. Now let's talk about the anion gap. What is the anion gap? The concentration of anions and cations in the plasma must be equal to maintain the electrical neutrality. Therefore, there is no real anion gap in the plasma. But it has been observed like the total difference between the positive or cations, the major cations, measurable cations, sodium and potassium, and the measured anion. Major cation anions are chloride and bicarbonate. So some of these cations and anions will lead to the difference of 16 milli equivalents per liters. So that gap is known as, the difference is known as anion gap. That it is actually nothing, because anion gap is physiologically, it's not real. A difference comes out because we haven't measured certain cations and certain anions, which are not measurable. So concept of anion gap was originally developed when it was found that if the sum of chloride and bicarbonate values were subtracted from the major cation sodium and potassium values, so the difference was found to be average 16 millimoles per liter in healthy individual. But most important, unmeasured cations include the calcium and magnesium because they are not generally measured, and the major unmeasured anions like the anions of albumin, phosphate, sulfate, and other organic anions. So these are all anions and they are not being measured. So that's how this difference comes out. Actually, there is no difference because, but numerically, like it is the difference between the major cation and anion, and unmeasured cations and anions have been neglected. So that's how the difference comes mathematically. So anion gap ranges between 8 to 16 milliequivalents per liter in the healthy person. So if there is a deviation from this anion gap, that also give uh, um, you know uh, information about the metabolic or respiratory disorders.